Well, hello and good evening. It is 7 o'clock and welcome to tonight's Health Equity Member Interest Group presentation, a CME program called Primary Care Essentials for New Arrivals. I'm Ginny Flynn, the Vice President of Communications and Member Engagement for the Academy, and it's my pleasure to introduce one of the two co-chairs of the Health Equity Member Interest Group, Dr. Ronald Rembert, Jr., to get us started. Dr. Rembert.
Thanks, Jenny. And welcome everybody to this evening's event. Briefly want to share with you, my name is Dr. Rembert, and I'm one of the co-chairs along with Dr. Andrea Haynes of the Health Equity Member Interest Group for the Illinois Academy of Family Physicians. Glad that you guys could join us this evening. We also want to share an upcoming event that we'll be hosting. It'll be a book club discussion on a book called Race After Technology by Dr. Ruha Benjamin, discussing the role of AI in not only the services and care that we provide, but even how this technology has advanced, but also has some concerns and drawbacks as well. Looking forward to a lively discussion. This will be Wednesday, August 27th, 7 p.m. At this point, I'm going to turn it back over to Ginny for some housekeeping rules and basically some information on the CME for this evening.
And just a reminder of our diversity, equity, inclusion policy, which we try to weave into everything that we do at the Academy. And certainly this tonight's CME webinar is an activity that reflects that. So for today's webinar, all attendees are in listen-only mode. Make sure you are muted and feel free to use the chat to submit questions throughout the event. There will be time at the end for Q&A, and that will include either written chat questions, or you'll be able to raise your hand and ask questions that way. And then all the questions and answers will be part of the recording. Then we'll stop the recording, and this presentation will be also available online on our website. So the faculty disclosure statement, because this is a CME accredited activity, the IAFP adheres to the conflict of interest policy, the ACCME or ACCME and the AMA. It's the policy of the IAFP that all individuals in position to control the CME content, sorry, my screen is covering up most of what I need to say, must disclose any relationships with ineligible companies upon nomination, invitation, of participation. Our speaker tonight, Dr. Victoria Kiermeten, our co-chairs, Dr. Ronald Rembert, Dr. Andrea Haynes, and myself, Ginny Flynn, with the staff, disclosed no relevant financial relationship or interest with a proprietary entity producing, marketing, reselling, or distributing health care goods and services. This accredited program will provide AMA PRA Category 1 credits if you're on with us live. If you're watching this online as an enduring credit, an enduring material, you will also be able to qualify for 1.0 AMA PR1 category credits. As far as claiming that credit, there is a link to a post-test that will be shared in the chat box several times and also emailed to you after the presentation. To receive a CME certificate, you must complete that post-test and submit it. Then your CME certificate will be emailed to you upon completion. The name on the field will be blank for you to fill in. Please note that IAFP maintains a record of CME credits. If you're watching this on our YouTube channel, here's the instructions on where to find that post-test evaluation and credit claim. You need to go to the description and make sure you click on more to see the rest of the description and find that link. And now it's my pleasure to turn it over to the other co-chair of the member interest group, Dr. Andrea Haynes.
Hey, welcome everyone. So excited to get this CME started. Here listed on your screen, you see our learning objectives for tonight. By the end of this course, participants will be able to define the legal status of new arrivals, conduct thorough initial visits, and manage vaccines efficiently and effectively. So now I'll introduce our presenter for tonight. Her name is Victoria Kiermeten. She's a second-year family medicine resident at Swedish Hospital, where she works with the vibrant underserved population through her clinic at Erie Family Health. She obtained her medical degree from St. George University of London and spent a few graduate years training in general medicine in England before starting her residency in Chicago. Prior to medical school, she earned a master's degree in global health at Duke University and worked in research. She has lived, studied, and worked in many countries, including Peru, Cyprus, and Ghana, and she hopes to continue exploring as a lifelong learner. She was selected as a scholar of the AAFP Emerging Leadership Institute for the 2024-2025 academic year, and through the application of her passion in global health and primary care, she created a curriculum for primary care physicians working with new arrivals in Chicago. Please now welcome Dr. Carrie Matson and enjoy this wonderful presentation tonight.
Hello, everyone. Welcome to our webinar today. Thank you for taking the time out of your evening. So we're going to start talking about primary care essentials for new arrivals. So our objectives, as we've already gone through, are to understand the legal status of new arrivals, be able to conduct a thorough initial visit, manage vaccinations effectively, identify and treat common health issues, including parasites and malaria, and then apply trauma-informed care principles to support mental health. So I will begin by asking you all to look at these pictures and think about words that you may use to describe the people in this picture. They are AI-generated images of what a refugee and what an expat are. Obviously, AI learns from us and our internet presence, so it's just something to think about what we all think about refugees and expats, and we'll talk a little bit about that later on. So the group of people that we're talking about in this webinar this evening are displaced people. And displaced people have been forced to flee their homes by conflict, violence, persecution, or disasters. And then if they leave their country, they are then known as refugees or asylum seekers. This graph really just shows how the UN Refugee Agency can help people, help support people who have left their home countries. So displaced people can be categorized into these 4 overall categories, and we'll look at the first 3. So a refugee is someone who has been forced to flee his or her country because of persecution, war or violence, well-founded fear of persecution for race, religion, nationality, political opinion, or membership in a social group. 73% of all refugees and others in need of international protection come from Afghanistan, Syria, Venezuela, Ukraine, and Sudan. An asylum seeker is someone who is seeking asylum or the right to be recognized as a refugee and receive legal protection and material assistance. People that flee their own country and seek sanctuary for all of the same reasons that you'll see listed for a refugee. The big difference really for people in America is that they've applied for asylum in America, whereas to get refugee status, they would have had to apply and been granted the status of refugee from their home countries. This isn't a universal definition, but in the United States, that's the legal distinction. An undocumented immigrant is someone who resides in the US without legal status. So this means they've entered without inspection. They did not present at an official checkpoint to obtain permission. They may have already entered with legal status, but overstayed their visa. Maybe they were part of the Dreamers, people who were given temporary reprieve from deportation. Many are in the process of legalizing. They're not provided work authorization, and immigration officers have the power to interrogate, search, arrest, and detain them. As you can imagine, there's a lot of overlap with undocumented immigrants and someone who may be an asylum seeker. And then there are internally displaced people. So this is someone who has been forced to leave their home, but never crosses an international border. So they've been displaced by internal strife, natural disasters. They are not protected by international law or eligible to receive specific aid because they should be protected by their home governments. So in the United States, you can think about the hurricanes in Appalachia or the fires in California, even domestic violence and things like that. There are 63 million people who are internally displaced around the world. Countries with significant internal displacement include Sudan, the Democratic Republic of Congo, Myanmar, Somalia, Syria, and Ukraine. So although the content of this webinar is to look at what we are calling new arrivals, it's really important to think about how labeling may affect a patient, a community, and an overall conversation. So labels alter perception, influence behavior of both the general population and those who are labeled. They can undermine public support, they can guide public opinion and frame political and social debates. By framing the conversation, you can influence an individual's perception by highlighting only certain parts of their stories. And you'll see on the right pictures of news articles from 2017 to 2024. A lot of it is focused on immigration, and there's definitely certain narratives that you can find. Using the correct terminology is really important to help identify specific needs of subpopulations. But it's important that we are aware of the possible stigma that may be attached to that. This next slide looks at the word immigrants and an expat. As was mentioned before, I spent some time working in England after medical school, and I was titled an expat. Many of my colleagues who came from other countries like India or Nigeria or Ghana were called immigrants. And I really could never find a very good reason as to why we were called something different. So in preparation for this curriculum, I looked up these words on Google Scholar, and you can see there's a very distinct difference in how the words are framed. When you look at expat, you see highly skilled, you see words like academics, return on investment. And then when you look at immigrant, it's associated with refugees, asylum seekers, illegality. And it just makes you wonder why there's such a difference when really the word means the same thing. So this is just another thing that we should think about when we're looking at labels and thinking about how it may shape an individual's experience. So this is a question that you may see on your screen for the Zoom. But the first question is, which of the following groups are displaced people? And the second is, there's an agreed upon definition of immigrant and expat. And Jenny, can you just let me know if you're able to share?
It does not seem to be. Oh, you know what? I may have another one launched. Give me one quick second and we will make sure that that's not in there. Let's see. There we go. Let's try this one. Okay. Are you seeing it now?
I can see it, yes.
Okay. It's open.
So it'll just be for the first two questions. If you all can just submit your answers.
They may only see the first one.
Gotcha.
Let's try that first. Let's give another couple minutes for some more people to weigh in.
And while people are filling that in, this is just a flashcard again, reminding us of the definition of a refugee and an asylum seeker. The biggest difference in the United States is where you are applying for this asylum. So if you're in America and you would like asylum and you're applying for it, you have to do it once you've arrived here. Whereas as a refugee, you would have done this in your home country or another country where you're seeking asylum. So I'll just go over the answers to this quickly. So which of the following groups are displaced people? The answer is all of these people are displaced. And then this question about an agreed upon definition of immigrant and expat, there is no agreement. All right. So, oh, great. Excellent. Okay.
It looks like it may have launched all the questions instead of just the first one.
Okay, that's fine.
Things that we learned. We'll try to do it again when we get to that point.
So this is a graph that I made last year and revisited at the start of this year. Some things, as we know, are changing, but in general, I wanted to make it clear what's available to patients who fall into these categories. So people who are refugees are eligible for private insurance through temporary high-risk pools and basic health plans. They're also available for everything else in terms of Medicaid, emergency Medicaid, community health clinics, and emergency medical care, which everyone is entitled to. For asylum seekers, they are not eligible for private insurance or most Medicaid options, but they are eligible for emergency Medicaid, and then also the rest of the other safety net, community hospitals and health clinics. There are some groups that are eligible for some care. So for prenatal care and 12 months postpartum, children, especially for vaccinations and your like routine well child visits, and then certain groups of adults if they were enrolled prior to 2023. And then looking at undocumented immigrants, again, they're not eligible for any of the Medicaid or private insurance, but they are eligible to receive care at community health clinics, safety net hospitals, emergency medical care, and then any programs that may come through the Department of Public Health. Okay, so then let's get into the primary care aspect. When a patient comes to see you and you don't know their legal status, for people who do have like an official legal status, they would have been required to have a legal medical exam prior to arrival. The legal medical exam will screen for any inadmissible health conditions, communicable disease, mental health disorders, substance abuse disorders, and it's comprised of a brief physical exam, a mental health evaluation, and then review of vaccination records. Likely you'll have a gonorrhea, syphilis, and TB screening as well. And everyone who has a formal legal status is required to have that prior to their arrival. Once they arrive in the United States, they will have a domestic medical screening exam. This is usually done between 30 and 90 days upon arrival. It can take up to 3 visits. As we know, primary care visits aren't always the longest, so and there's a lot of ground that has to be covered. This exam has to be completed by a medical panel physician, which is requires a specific level of training. It will include a complete history and physical exam, including skin, document any bruising or injuries. These examinations and reports can be used as legal documents, which may be really helpful for patients applying for asylum. We know that patients who have forensic medical examinations, 81% of those applicants are successful in getting immigration relief, as compared to about 42% of those without a forensic medical exam. If it's something you're interested in, there is an online asylum training institute that's about a 7-hour course, and you can get certified to participate in this as well. For those of us seeing patients that do not have an official legal status or their legal status is unknown, we approach the primary care visit a little bit differently. Primary care visits are a great opportunity to develop a relationship with these patients, obtain a full history, review their records, screen for any medical conditions, and then also help to acclimate them to the US healthcare system. In addition to their routine questions, you'll want to ask about medications during their journey before and afterwards, and then also look at things like nutritional practices and norms, as well as screening for mental health conditions, including mood disorders and PTSD. So you'll see on the right, 3 big boxes. One is looking at your basic bread and butter medical history, birth history, especially in a pediatric patient, family history. Again, thinking about their treatment and any medical care that they've received before and during migration, hospitalizations. And then we'll look at mental health screening. Diet and nutrition is really important in this population. There are some groups that have known microdeficiencies like B12. Looking at employment, living accommodations, and asking about travel plans really helps you to stratify their infection risk. And then when you look at your vaccine records, you want to see a documented month and year of the vaccine and make sure that it's given at an age that's consistent with the CDC recommendations here in the States. These are some of your physical exam considerations. These are really the micronutrients that we may or may not think about in a patient that we wouldn't consider to be a new arrival. So looking at things like dermatitis, hair depigmentation and dryness, big hot spots for vitamin A deficiency, goiter, dentition, thiamine deficiency, manifesting as beriberi or symptoms of heart failure, your MSK, rickets with vitamin D deficiency, any of the neurological manifestations you may see. And then you'll also want to consider lymph node exam and genital exams in these patients. So these are just a few pictures and I'm going to flip for everyone. So this is glossitis, which is associated with vitamin B12 deficiency. This is MSK deficiencies associated with vitamin D and rickets. This is an example of a big hot spot, the vitamin A deficiency. This is dermatitis that you can see with niacin deficiency. And these like petechial things you can see with scurvy or vitamin C. So then talking about the screening labs, in patients that don't have records of their vaccination, you'll want to get an MMR, especially now, varicella, Hep A, Hep B, Hep C. You want to also be thinking about parasitic infections in new arrival patients. You can see that through CDC looking at eosinophils, platelets, anemia. You may want to consider serology if you have a high suspicion of certain parasitic infections, and then also consider stool studies with PCR. For infectious disease, you want to look for HIV, any of the many STIs, tuberculosis, and again, hepatitis. And then our routine labs with our bread and butter of primary care, screening for diabetes, lipid disorders, and other chronic illnesses. And then if the history and exam support it, you may also consider micronutrient levels. So for US-bound individuals that have refugee status, they are not required to receive vaccination prior to arrival, but many people would have come on the journey. They may have sought asylum in another country before coming to the United States and received vaccination there. People who have official legal status are required to complete all CDC recommended vaccines prior to arrival, and this includes all of these listed here. When a patient comes to your clinic and you have their vaccine records, or you don't have their vaccine records, you really want to prioritize communicable disease to prevent outbreaks. In pediatric patients, you want to give them varicella and MMR at the same time so that you don't have to wait a month to give one versus the other. And then you also want to try and prioritize school-required vaccines so that it does not prevent their initiation into school. You want to resume any incomplete vaccination series. And then when you're thinking about their previous vaccinations, it's really important that it's documented and not really just a hearsay, asking a patient if they had their childhood vaccinations, because there can be some differences in terms of what was required in their home countries and also the time in which it was administered. The documentation should include the patient name, date of birth, the date of administration, at least having a month and a year, and the full name of the vaccine. These are a few pictures of some vaccination cards. This is the WHO or International vaccine record. This is an immunization record from the United Kingdom. This is a card from Namibia. And this is one from Haiti. As you can see, there can be a lot of variation and a lot of challenges in interpreting and understanding what vaccinations were given and when. And there are some resources that you can use to guide you. So there's the CDC Pink Book, the American Academy of Pediatrics Red Book Online. Both of them are great resources in terms of when vaccinations are supposed to be given, any catch-up that needs to be done. Immunize.org has a translation of all vaccines and manufacturers throughout the world, so you can go and look through that. The Department of Health for Minnesota has excellent resources for new arrivals, but they also offer translation of vaccination forms. And the other two special considerations are BCG, which is a vaccination against tuberculosis. It's given within 28 days of birth or up to 5 years after birth. You'll usually see that on the upper left arm. Common countries are many throughout the world. So the UK, Japan, France, Russia, and many, many developing nations use the BCG vaccination. This is important because if you decide to screen a patient for tuberculosis with the PPD skin test, it will be positive. So you'll either need to get the X-ray, or you may just consider starting with the Quant Gold for these patients. Also, in relation to the polio vaccination in the United States, we use IPV. Many countries in the world use OPV. It's usually sufficient, but there are some cases where you would need to re-vaccinate with the IPV. So if there's incomplete vaccination, if there's an increased risk of exposure, or if patients receive the bivalent OPV. Listed in the chart are a few countries organized by continent where you can still see the oral polio vaccine used, and you may need to consider giving them the IPV. You can use the resources mentioned on the last page, or you can contact your local Department of Health for assistance. Specifically in Chicago and Illinois overall, there are high rates of varicella in children and adults. And as there have been documented outbreaks of hepatitis A. We now currently have about 6 cases in Illinois of measles. All of them are adults. 2 of them are in Cook County and 4, I believe, are in the South. So these are things that we should think about when treating patients in Illinois. Okay, this is the other question that you all may have seen already. I'm not sure if we'll be able to do the Zoom question again. So the question is, a 6-year-old new arrival comes to your clinic in July for her first medical exam. She has no record of her vaccinations. What vaccinations will you administer today? I'm not sure if people have, I minimized it, so I can't see if people have already answered it, but I'm going to answer together. So she's 6 years old. She's too old for the RSV vaccination. She's too young for the HPV. And then we have MMR and varicella. So we would, good, perfect. We will give both MMR and varicella and give it at the same time. Again, we don't want her to have to come back for another visit to get the other vaccination. We would also prioritize things like COVID and flu and any other school required vaccinations. I wanted to briefly talk about the Darien Gap because it's a path that many patients coming to Chicago or Illinois travel through. It's a 60 miles wide trek and it takes more than a week to complete. It's between Panama and Colombia, and it's full of mountains, swamps, and dense jungle that prevents good infrastructure. People can only travel by foot to get through the gap, and some people will use coyotes or guides for the journey. The journey and the gap are full of paramilitary forces, drug traffickers, and gangs. And in addition to all of that, it's one of the wettest countries in the world with temperatures greater than 95 degrees Fahrenheit. Although it is between Colombia and Panama, there are many people who come from outside of that area. In 2022, there were people from Senegal, the Democratic Republic of Congo, Bangladesh, Uzbekistan, and China. And in 2023, one-fifth of the people who crossed through the gap were children. These images were taken from the Council of Foreign Relations, which has really great photojournalism of the Darien Gap. Which brings us to some of our infectious disease risks. So we often think about parasitic illness and new arrivals. So for schistosoma, there is a seroprevalence of over 70% in people coming from sub-Saharan Africa. For strongyloides, there's a 25 to 46% seroprevalence amongst Southeast Asians who are new arrivals. And then Giardia is just our most prevalent parasite. Often symptoms can be vague, subclinical, a lot of abdominal pain, bloating, sometimes even difficulty gaining weight. And so that should put in our minds or make us think about some possible causes of that in terms of like parasites and new arrivals. So labs we would want to order are eosinophils. If you have a high suspicion, you might consider some IgG serology for schistosoma or strongyloides. You would want to consider stool and oviparasites testing or PCR testing. And then for Giardia, the PCR and stool antigen. You can consider presumptive treatment, which means just treating the patient, assuming that they have exposure, but there are some caveats. For schistosoma, praziquantel is generally fine as a presumptive treatment, but for strongyloides and looking at ivermectin, there is a type of strongyloides called loa that is associated with encephalopathy if it's treated with ivermectin. So if your patient is coming from a country where there's a higher burden of loa, you want to avoid any presumptive treatment and make sure that that's actually what the patient has, and also that they're not at increased risk of this encephalopathy. In the past, this has been, there was presumptive treatment with ivermectin and some refugee camps in sub-Saharan Africa, which led to increased amounts of people with encephalopathy. For Giardia, there is no presumptive treatment. You'll just wait for your culture to come back and then treat appropriately. Also, helminths are something that we should be thinking about in these patients. So your roundworm, your whipworm, your hookworm. Again, you can get abdominal pain, diarrhea, some vague or subclinical symptoms. In your labs, you'll be looking for anemia or eosinophilia. And to test for all of the roundworm, hookworm, and whipworm, you'll want to do 2 separate stool and oviparasite tests that are at least 12 to 24 hours apart. And you can treat it with albendazole. Also something very reasonable to consider as presumptive treatment for people. And when you see patients coming in, as you're getting your initial history from patients, it's reasonable to ask them if they have a history of deworming or taking any medication against parasites, as it's pretty common practice in many countries outside of the United States. I wanted to briefly mention malaria. So for Plasmodium falciparum in the endemic areas, symptoms usually will present within the first 3 months of arrival. After the first 3 months is less likely. This is most common in sub-Saharan Africa. Your signs and symptoms will be fever, myalgia, headache, abdominal pain, diarrhea, splenomegaly, rarely and thrombocytopenia. You can test it with PCR or blood smears. You'll want to make sure that the films are taken 12 to 24 hours apart. And then the PCR is best for subclinical malaria. You can do presumptive treatment again for malaria, especially if the patient is coming from an endemic area and you think it's most likely Plasmodium falciparum. However, if the other types of malaria or they're coming from places where the other types are more common, you should not do presumptive treatment. Other vector-borne illnesses to consider are things like dengue, yellow fever, and leishmaniasis. The symptoms are fever, nausea, cutaneous lesions, rash, and jaundice. So your index of suspicion for some of the more rare conditions in the United States should be higher amongst new arrivals. So again, these are the pictures that we looked at on the previous slide for in the Darien Gap, and there are many infectious risks that I think we can all identify. So when you're looking at unclean water, you think of schistosoma or giardia. With mosquito-borne disease, you think about malaria, dengue. All of these are common year-round in the Darien Gap. In contaminated soil, your strongyloides, hookworm, roundworm, whipworm. And I think you can see all of the examples of all of this in those pictures. Again, talking through this question, what presumptive treatment would you consider? So ivermectin, we mentioned we don't want anyone to have encephalopathy. So without knowing more of the story, we would avoid ivermectin. I think no medication is a valid answer if you want to get full testing. But because the question asks for presumptive treatment and we have to pick one, the answer is Alvin. Okay, so let's talk about mental health and new arrivals. As you can imagine, prevalence varies greatly and it's likely underestimated. There are a lot of delays or disrupted care in patients who are new arrivals, and so it's hard to quantify. But there are some estimates that find more than a third of asylum seekers have PTSD, more than a third have anxiety disorder, and about half have symptoms of depression. We know that depression and anxiety plus non-DSM measures of distress are higher in this population than the non-new arrival population. And it's hypothesized that the constellation of symptoms may be related to constant state of instability, insecurity, like financial insecurity, housing insecurity, and some hypervigilance. And there's this idea of acculturative stress, which is stress that is experienced by immigrants as they try to adapt to a new culture while preserving their own culture. This specific type of stress or distress is associated with increased alienation, depression, anxiety, marginalization, heightened psychosomatic symptoms, and identity confusion. This is a graph that I made looking at a lot of the literature that's out for trauma and mental health in the new arrival population. And I think you can really group it into three big categories. So there's violence, legal status, and identity and culture. With the violence, it's domestic violence, bodily injury, witnessing it. This may have been the reason why a patient left their country to begin with, or may have encountered it in the journey to the United States. Legal status is associated with diminished social status, discrimination, sickness because of barriers of access to healthcare, fear of immigration enforcement, also not having a history of deportation, which has to do a lot with interpersonal guilt that some new arrivals may have, which we'll talk about in the next couple of slides, and isolation. Looking at identity and culture, there are some protective factors that are really associated with belonging to a bigger group or their religion. But then there are some risk factors like language barriers, and then some identities that are associated with their social status within their families. So for mental health screening, the WHO recommends either using a single screening tool like the Refugee Health Screener or the Minnesota Wellness and Emotions Check, or the WHO-5, or using a combination of screening tools. We want to make sure you always are screening for anxiety and depression, trauma, and substance abuse. The triple trauma paradigm is, it highlights overlapping and compounded effects of trauma, particularly in how it affects all aspects of health. When addressing trauma, clinicians should really look at it holistically. So there are three parts of the triple trauma paradigm. The first part is associated with your country of origin. This is your historical trauma. This may be the reason why you left your country to begin with. The flight is the journey to going from your home country to another country. There's a lot of physical danger, emotional trauma, guilt of leaving others behind. You can also see this in the interpersonal trauma. So guilt associated with leaving people behind, either in your country of origin or throughout your journey. And then like the isolation that's associated with that. And then the third category is the host country trauma. So this is the trauma that that is a result of arriving into a hostile legal system with hostile residents, social isolation, loss of family, culture, and identity. And this is really structural, but this is also where we as primary care providers really can play a role. In pediatric patients, trauma is often behavioral or somatic. So in preschool children, you can see bedwetting or thumb sucking, almost some like regression in terms of their behavior. And as they grow into elementary school children, you can see changes in their behavior as well, increased irritability, withdrawing from others, difficulty at school, fear of separation from their parents, this feeling that something bad is going to happen. And in older children, you can see a sense of responsibility or guilt, shame and embarrassment, problems, again, interpersonal problems with their peers and family and teachers, and conduct issues. So when we are treating patients, we have to look at their trauma overall and holistically and try and apply trauma-informed care. Trauma is defined as events or circumstances experienced by an individual as physically or emotionally harmful or life-threatening, which results in adverse effects on the individual's functioning and well-being. Principles of trauma-informed care are promoting physical and psychological safety, building trusting relationships with patients and families, providing peer supports, collaborating with patients and families, supporting and fostering agency, and promoting intersectionality. And although we should do everything we can as primary care providers and primary care doctors, we have to really make sure that our institutions support us. So we should try and encourage our institutions to create a safe environment for new arrivals, to evidence that diversity is welcomed by using positive and welcoming language, using interpreters throughout their entire time, which can be on the phone when scheduling or in person when they're at the front desk with your medical assistants, your nurses, as well as you going in as the physician. You should ask your patients about their comfort throughout the visit. Do they want the doors open? Do they want it closed? Make sure that you're explaining anything that you're doing, any intimate exams, really making sure that they're comfortable before proceeding. Here are a few strategies. So using strength-based care, acknowledging and promoting strength, and also that informing patients that there is a way forward. A diagnosis doesn't end there. There are ways to heal from the trauma. Preventing re-traumatization, which is really, again, talking about that triple paradigm and that third category of not being a hostile environment. Promote trusting relationships, letting people know that this is a safe place through a window of tolerance, asking if it's okay to discuss things. Like, I know a lot of people have a difficult time when they travel here. Is it okay if you tell me about your journey to Illinois? Recognizing the impact of trauma, the manifestations, and screening, because if we can't screen it, we can't diagnose it. If we can't diagnose it, we can't treat it, which is our next strategy. And then using a multi-generational approach. It's very helpful with pediatric patients, but all patients in general. Knowing your local resources, making sure that they are safe and trustworthy, understanding and acknowledging that the trauma does not end once they have arrived into Illinois. And then advocacy. The IAFP website has a lot of excellent resources on how to be an advocate for our patients, ourselves, and our communities that we're a part of. So this is our last brief case. So a patient has arrived with unknown legal status and has abdominal pain. Which questions will you include in your history? And you can select more than one. So I'll give you a minute to answer those. Okay, and then I'm just gonna go ahead and talk through some of these. So, great, perfect. So asking if a patient has been hospitalized is a great thing to do. It lets us know if they have any medical conditions. It's also a way to see if maybe on their journey they've been hospitalized. Asking about legal status is unnecessary. There's no legal requirements to ask a patient what their legal status is, nor is it advisable, knowing that there's a lot of stigma that's associated with it, and it can affect a patient's trust in you and affect their care in the future. So we won't do that. Asking the patient to tell us about their travel to Illinois, that can let us know if they've been here before or if this is, their new arrival. I often ask if a patient has seen any other doctors or the last time they saw a doctor and where that doctor was. And then asking if a patient has a history of deworming or taking any medications against parasites can also help us to stratify their risk. So those are those answers. And then the last question is, which scores can you use to screen for mental health in new arrivals? So I'll give you a minute. So just talking through, we know that we want to screen, right? When we're thinking about trauma-informed care, when we're thinking about mental health and new arrivals, we should always do a screener or many screeners if there's time. So let's see the results. Great. So all of these are things that you can do for the single substance. That can take you into audit or DAST or any of the other ones looking for substance abuse or alcohol use, and then your refugee health screener. All of those are options. There are many options and you shouldn't feel limited when it comes to the scores. Okay, so in summary, since 2023, there have been over 23,000 new arrivals in Chicago. Each patient has their own set of unique needs that necessitate a tailored approach in primary care. Access to primary care in Chicago comes through many different sources. And it's important that when a patient comes, we review vaccination records, their exposure to infections, look at their nutritional status, and identify any additional needs. So hopefully now you feel comfortable taking a comprehensive medical history, screening for parasites and other infections, looking for mental health and trauma, and then routine bread and butter primary care common comorbidities. I got this quote from a refugee workshop that I attended from Yasin. This Burmese refugee was speaking with other refugees about the importance of community support. And he said, "No one chose to be a refugee. No one chooses this life, but together we can have a better experience." And that really resonated with me because as a family physician, I want to also do what I can to help us all live a much better life. And these are some of the collaborators, faculty from Swedish Hospital, Dr. Boisel, Dr. Bott, some of my co-residents, Dr. Sosa, Dr. Ahmed, Dr. Bashfarai. And this was made as a part of the ELI Emerging Leaders Institute program with the AAFP Foundation. So that's it. Any questions?
I love the heart because this presentation certainly has quite a bit of heart into it. Dr. Karamotin, thank you so much. At this time, you are welcome to insert any questions you have through the chat, or because this is set up as a meeting, you are welcome to use that raise hand feature and we can take any questions you might have live. And just a reminder, the link to submit evaluations and claim CME credit is also in the chat. Twofold, we want to make sure you get the CME credit, and two, we would absolutely love your feedback on tonight's presentation as well. It's a quiet group. Oh, a question from Teresa D'Souza. What is the major difference between the PHQ-9 versus the refugee questionnaire to screen for mental health?
Good question. So the refugee health questionnaire looks at overall well-being, whereas PHQ-9 is really looking at signs of depression. So it's really focused on just that mood disorder, whereas the refugee is just an overall wellness score.
And Dr. Rembrandt, you can always, of course, unmute and ask, or if you are not in a place to do so, any concerns with documenting patient immigration status about issues with ICE?
Yes, so there are a lot of different things that we just didn't have time to go in today, but when it comes to documentation, really you should avoid documenting any immigration status. It's HIPAA, it's protected, but if an ICE agent comes and sees something in plain sight, which means they walk into a room and they see something or they hear something, it can be used in a case against someone. There's no reason to document anyone's legal status. If you need to know for your own self, you can think of vague, non-specific things like a patient saw a doctor in insert whatever country it is that they saw, but you shouldn't really document at all if you can avoid it.
Thank you for that. I will hold on for any other questions, either through the chat or if anyone wants to unmute and ask a question. All right, you must have covered all the bases. It was certainly a lot of fantastic information. With that said, I will go ahead and stop the recording.